So that was PRODIGY. Now let's turn to the other trials. And what do the other trials tell us about duration of antiplatelet therapy? So first off, this is PCI-CURE and CREDO. And these trials said that 1 year of Clopidogrel was better than 1 month after a bare metal stent. So that's interesting to know, right? So bare metal stent, 30 days? Well, PCI-CURE and CREDO say you can have a better outcome if you extend that to 1 year. Interesting. And what about this slide? Wow. So as you can see, a lot has gone on in terms of studies, and it's still an unresolved issue. So wow, let's look at this list of clinical trials that have looked at duration of dual antiplatelet therapy after cardiac stent placement, and some of these are ongoing studies. So I'll just read these off. DAPT, ICER-SAFED, REAL-LATE, ZEST-LATE, ITALIC, DATE, OPTIMIZE, Seaside, Excellent, and RESET. And I'm sure there's more. So those that were randomized, I'll name these off as well. Randomized included DAPT, ICER-SAFED, REAL-LATE, ZEST-LATE, OPTIMIZE, Excellent, and RESET. Okay? DAPT is by far the largest trial on this list. So DAPT had 20,000 plus patients comparing 12 months versus 30 months of dual antiplatelet therapy. Now, admittedly, I don't know these trials well at all. Okay, I can tell you this. DAPT is ongoing, so 12 versus 30 months of dual antiplatelet therapy. So those results will take a while. ICER-SAFE, I believe, is still ongoing and should end December of 2012. And that is 6 months versus 12 months of dual antiplatelet therapy. REAL-LATE, that was published in the New England Journal in 2010. And that said it was okay to stop dual antiplatelet therapy at 12 months compared to 24 months. Okay, REAL-LATE, 12 versus 24 months. You can stop at 12. ZEST-LATE, I'm going to skip because this received a lot of criticism for its trial design. The ITALIC study, I believe, is an observational study looking at 6-month cutoff for DAPT. DATE, that was published in 2010. First author, J.Y. Han, and that actually showed that in low-risk patients, it was okay to take them off dual antiplatelet therapy at 3 months. Now, DATE was not randomized, and it had a small sample size, okay? But it suggested low-risk patients can come off at 3 months. OPTIMIZE. This is an ongoing trial and compares 3 months of dual antiplatelet therapy to 12 months. And that's the one I can't wait to see because I think less is better. And hopefully that trial can prove me right. Seaside is a study that I am unfamiliar with. Excellent was randomized and suggested it's okay to stop dual antiplatelet therapy at 6 months in low-risk patients. Likewise, RESET, that was also randomized and suggested it's okay to stop dual antiplatelet therapy at 3 months in low-risk patients. Now, a lot of these studies were small, okay? So criticized for being small. But the bottom line is if a patient is low risk for an ischemic event and high risk for bleeding, it seems reasonable, definitely reasonable, to use clinical judgment and stop dual antiplatelet therapy. And you have plenty of trials to support you. Now, Clopidogrel pharmacogenomics. We're not going to go into very much detail here. I want to mention it, however, because this too seems to have generated a lot of controversy and it remains an unresolved issue. Now, the background, what you should know is that clopidogrel is a prodrug. It's metabolized in the liver by the CYP2C19 enzyme system, and it's been estimated that maybe up to 14% of patients are poor metabolizers. And that was the statement the FDA made in 2010. Now, other sources give different percentages, some higher even. So this means that you don't get the full antiplatelet inhibiting effect in these patients. Now, unfortunately, we don't know who these patients are unless they've failed therapy on clopidogrel, and then sometimes we still don't know. Okay, so then the million-dollar question is, what should we do? Okay, so one thing is we can do platelet function assays, right? So, well, that's what the GRAVITAS trial looked at least, and there was no benefit on cardiovascular disease outcomes or stent thrombosis with 2 times the loading and maintenance dose in stented patients who had high residual platelet activity. Okay, so GRAVITAS trial looked at patients who had high residual platelet activity, and they gave them 2 times the loading dose for a total, and maintenance dose for a total of 6 months. Okay, so 600 loading dose and 150 maintenance dose. And that was a negative trial. Okay, TRIGGER-PCI was a trial comparing clopidogrel to prasugrel, Effient. However, that got halted due to a low event rate. And then TRILOGY Platelet Function Study, that one is ongoing. So the TRILOGY Platelet Function Study is ongoing. Now here's a manuscript from Ghannudi et al., published in 2010, JACC Cardiovascular Interventions. So Ghannudi et al. Found that low responsiveness to clopidogrel, assessed by the VASP flow cytometry test, conferred a 4-fold hazard ratio. Okay, so stent type also appeared to be an issue. So this study did suggest that platelet function assays may be useful. So this comes from a prospective registry, by the way, not necessarily a randomized control trial. This is a prospective registry, Ghannudi et al. And what about the CYP2C19 genotyping? Again, an unresolved issue and pretty controversial. So should we be genotyping people for the CYP2C19 mutations? And let's look at a paper from JAMA. So here's a meta-analysis, which for me personally, it's not the be-all, end-all. In fact, I think meta-analyses have spawned a cottage industry over the last 10 to 15 years, thanks largely because of technology. They're easy to do. And by the way, try and name the last medication that was FDA approved because of a meta-analysis. I think that would be aspirin. And I think the indication was for secondary prevention in coronary artery disease, but don't quote me on that. So that should hopefully tell you something about the merits of a meta-analysis. And I don't mean to discredit them. I think they're very useful, but I'm just saying. Now, anyways, JAMA 2011. And I'll read the abstract conclusion verbatim. Here it is. Although there was an association between the CYP2C19 genotype and clopidogrel responsiveness, overall, there was no significant association of genotype with cardiovascular events. And this meta-analysis looked at 32 studies comprising over 42,000 patients having about 3,500 cardiovascular events. And interestingly, there was a signal between genotype and CVD event seen, hazard ratio of 1.18, and that's not much of a signal. But then they restricted the meta-analysis to studies having 200 or more events. And then you can see that the point estimate was attenuated. All right, so here's a study worth mentioning. This is called ELEVATE-TIMI 56. In this study, they did genotyping first and then looked at different doses of clopidogrel. For example, 75 milligrams, 150, 225, and 300. And then they assessed platelet reactivity using both the Verify Now assay and the VASP test. And basically, they show that you can, in fact, decrease platelet activity in the heterozygote and homozygote CYP2C19 carriers if you increase the clopidogrel doses. And in some instances, it's as good as the non-carriers. So ELEVATE-TIMI 56 assessed platelet reactivity in genotyped patients at increased clopidogrel doses over a 14-day period. So only 14 days. But it did show 2 important things. Number 1, you can increase platelet inhibition in heterozygote and homozygote CYP2C19 carriers. And number 2, patients tolerated the higher doses of clopidogrel. So there weren't any untoward effects of high-dose clopidogrel. Now, events were very low, but again, this was only a course of 14-day higher clopidogrel doses. Okay. So in summary, so it's okay to stop clopidogrel at 6 months after cardiac stent placement. So whether it's drug-eluting stent or bare metal stent, especially if there's a bleeding risk. Okay, and that is what PRODIGY tells us, and that's what several of those other trials tell us as well. Now, there may actually be a slight benefit to extending clopidogrel dual antiplatelet therapy, that is, to 9 months or maybe 12 months, and that's based on some other trials like CURE and several others. dual antiplatelet therapy for 2 years post-stenting increased bleeding in PRODIGY. So more trials to come in dual antiplatelet therapy duration, in Clopidogrel pharmacogenomics, and platelet function testing as well. Okay, best part, worst part. So for me, worst part, this is a small trial, and that's been a problem with other trials like this. And the other thing is we only get 2 time points for dual antiplatelet therapy, right? At 6 months or 24 months. Now we do have the DAPT trial to look forward to, and that has around 20,000 patients. And also in DAPT, they're looking at 2 time points, 12 months compared to 30 months. So my question is, how are we going to be able to take the results from DAPT and compare it to the PRODIGY trial? So, what kind of crazy meta-analysis is going to stem from all these studies? I don't know. And I think in a perfect world, all the trialists would get together and do one big study, gather up all the patients, and look at dual antiplatelet therapy at several time points. For example, 3 months of DAPT, 6 months of DAPT, 9 months of DAPT, and so on and so forth. But that's not how we do clinical trials. We always see a new interventional treatment and a comparator, or 6 months versus 24 months. It seems like we're always comparing 2 things. Okay, so there's a winner and a loser. And that's what we're comfortable with. So we've accepted a p-value cutoff 0.05 to tell us whether there's a difference between one thing versus a second thing. Now, I'm not sure where this comes from. I'm not a clinical trials expert, but I'm just asking, why do we always compare just 2 things, a winner and a loser? It's kind of like sports, right? Someone wins, we're happy. Someone loses, we're upset. It's definitive, so you either win or lose, so I like that. But could this be possible? Could we compare 4 things? So for example, dual antiplatelet for 3 months, compared to 6 months, compared to 12 months, compared to 24 months, and find out which is best? If so, why wouldn't we do that? So if anyone can answer this question for me, I'd greatly appreciate it. I don't have the answer. So for me, this is the worst part. Small trial, only 2 time points, and it's hard to compare this to other dual antiplatelet trials. Now the best part. So this study, I feel, can guide our clinical management in patients. So we can comfortably say that it's okay to stop dual antiplatelet therapy. Many clinicians out there, like me, were taught to give dual antiplatelet therapy for 1 year after a drug-eluting stent. And therefore, a lot of clinicians are going to be afraid to stop dual antiplatelet therapy, even in the face of bleeding. And I've seen it, and I'm sure many of you have too. So you get consults on patients like this all the time, right? So I like this because now we can be more confident in recommending dual antiplatelet therapy to be stopped in the setting of high-risk bleed, etc. And that's all for today. And hopefully this didn't bore you, it might have. I hope it didn't. But I've seen talks on this topic. I know how frustrating it can be because of all these trials and all this data and this fine balance between thrombosis and bleeding. But think about it. That's the cornerstone of acute coronary syndrome. Anyways, thanks for joining. Until next time, so long and goodbye.